Good evening, everyone. I am Dr. Vijayalakshmi. I am going to present a class on penetrating keratoplasty, moderated by Dr. Niveditha ma'am. Penetrating keratoplasty. It is the surgical replacement of diseased host corneal tissue by healthy donor corneal tissue. If it involves full thickness, then it is penetrating keratoplasty. If it involves partial thickness, then it is lamellar keratoplasty. History. In 1905, Edmund Zerm performed the first successful corneal transplantation from a live donor. In 1911, anterior lamellar keratoplasty was performed by using a preserved donor cornea from human cadaver. In 1944, first eye bank was established. Into the epidemiology, according to global survey, corneal blindness is the fifth leading cause of blindness. Out of 45 million blind people, 8 million are blind due to corneal diseases. 5.5 are bilaterally and 6.2 are unilaterally blind due to corneal diseases. According to National Blindness and Visual Impairment Survey, India, 2015 to 2019, corneal blindness is the third leading cause of blindness, and in India, its prevalence is around 0.88%. According to WHO, 7 million patients avoid keratoplasty. Classification. Optical. To obtain a clear visual access for visual rehabilitation. Refractive. In cases of keratoconus, reconstructive or tectonic PK is performed to improve the corneal integrity, and therapeutic PK is performed to remove the infected cornea. Cosmetic PK is performed in cases of whitish corneal scar. Indications. Optical. Optical PK is indicated in pseudophakic or aphakic corneal decompensation, stomal corneal dystrophy, primary corneal endotheliopathy, corneal ectasia and thinning, congenital corneal opacity, acquired corneal scars, non-infectious ulcerative keratitis, corneal degeneration, failed corneal graft. Therapeutic PK is being performed in non-healing infectious keratitis with perforation, post-chemical injury with melt. Tectonic PK is performed in corneal ectasia, corneal perforation, corneal melt, corneal thinning with desmetocele, and post-chemical injury. Based on the prognosis, keratoconus, central or paracentral corneal scars, stomal dystrophy, early central Fuchs endothelial corneal dystrophy have excellent prognosis with more than 90% success rate, whereas severe chemical or irradiation injury, ocular cicatricial pemphigoid or Stevens-Johnson syndrome and neuroparalytic diseases, they have poor prognosis with less than 50% success rate. Contraindication. Relative contraindications include.
Let us just pause in a minute. So go back to the previous slide. So you said 90% and 50%. Can somebody tell me how do you judge the prognosis in penetrating keratoplasty?
Ma'am, if there is more than 2 quadrants vascularization, if there is limbal stem cells are there for the epithelial regrowth, any of the severe chemical injuries or dry eye like Stevens-Johnson syndrome, that can have poor prognosis. Edema or multiple grafts have been done before, they'll have bad prognosis. Pre-op already IOP is uncontrolled, they'll have bad prognosis. Age less than 40 years is a high risk factor. Larger grafts, eccentric grafts, intra-op complications which can be there.
So when you are now enumerating the causes for like what she has already said, yes. 90% prognosis, 50% prognosis, that causes you are enumerating. What I want to know is, in a life of a graft, how do you gauge the prognosis? This 90% is for the rest of the life? No. So,
for the pre-operative, like how we gauge the prognosis wise?
A prognosis for the rest of the life of the patient or any stipulated period this prognosis?
1 to 2 years, I'm guessing.
1 year is the usual prognosis prediction that you... First step is 1 year prognosis, then is 5-year prognosis, then is 10-year prognosis. So in the initial 1 year, why that initial 1 year is so important in a corneal transplant?
Graft rejection chances.
So the maximum, whatever 90% survival or whatever that we are saying, the maximal rejection, if it is 10% to 50%, occurs in the
1 year.
90% of the rejection rate, 85 to 90% of the rejection rate happens in the initial 1 year. So it is very, very important to cross the initial 1 year period. Okay? So that is what is important. Understood? Yeah.
Contraindication. Relative contraindication, including epithelial dysfunction due to limbal stem cell deficiency, neurotrophic keratitis, dry eye states, stomal vascularization involving more than 2 quadrants, and multiple graft failures. All this condition will result in increased risk of graft rejection, and absolute contraindication is being nil visual prognosis. Advantages. Familiarity with the procedure and relatively good post-operative track record and full thickness eliminating interface related problems. Disadvantages include lengthy post-operative course, allograft rejection, and suture-related complications like tight suture, loose suture, suture abscess, weak graft-host junction resulting in wound dehiscence, wound leak, and irregular or high corneal astigmatism resulting in anisometropia. Preoperative evaluation. General evaluation of the patient, including systemic illness, control of hypertension, diabetes mellitus, any associated systemic diseases, history of allergy, systemic medications such as anticoagulants has to be investigated. And social and family support system, because the patient has to be put under long-term post-operative follow-up and the patient has to use the ROPS regularly. So social and family background has to be inquired. The patient has to be counseled about the outcome of the surgery and the risk factors associated with it and the post-operative outcome. Ocular history. In ocular history, the presenting complaints, diurnal variation with vision, previous surgery, glaucoma procedures, glaucoma drainage devices, trabeculectomy, and any posterior segment procedures, and use of anti-glaucoma medications has to be recorded. Visual acuity preoperatively has to be noted, and gross ocular examination, detailed slit lamp examination starting from lids, lid abnormalities like ectropion, entropion has to be corrected preoperatively. And in conjunctiva, dry eye state, neurotrophic keratitis, and ocular surface disorders. In cornea, the depth of corneal ulcer, vascularization, then fundus examination. In fundus examination, if the media is not clear, ultrasound B scan can be taken. And intraocular pressure has to be noted. Investigations include tear film assessment, pachymetry, ultrasound biomicroscopy, and ASOCT is done in cases of anterior segment with poor visualization, and electrophysiological tests are also being performed.
Yeah, let us pause here a little bit. When we look at a patient who is a potential for having a penetrating keratoplasty, she has enumerated most of it, but one very important in the gross ocular examination. Can somebody suggest what will you look for in the patient face around the eye? Important when you are planning a corneal intervention. One of you, the other person.
Ma'am, we look for lag of thalamus, any exophthalmos is there.
Why?
Because the corneal exposure can lead to epithelial defects following SPK.
Okay. Anything else?
Any gross infections in the eyelid, like any
Specifically for
meibomitis.
these patients could have infection. You might be doing a penetrating keratoplasty for a corneal infection. So that infection is not the answer. Anything else? Take the mic, please. So when the patient is having infective keratitis, you are doing penetrating keratoplasty, you have to look for log ophthalmos. You have to look for exophthalmos. Okay? In a similar pattern, anything else that you will look for. Because that could be an often comorbid condition in an ulcer. Forget about ulcer. Anything else? You gross eye examination, eyelid. Very good. Very good. So any comorbid corneal. Why do you want to look for that? Take the mic, please. There are people in the online forum also.
If there is nerve palsies, then there may also be a loss of corneal sensations, which can later lead to like neutrophic ulcers.
So you might have healing issues in the post-operative period. So you don't want a complicated scenario, or you want to at least be aware of it. Okay. So that might help you in determining the size of the graft, all those things. Okay. Or you want to combine it with a torsorrhaphy or amniotic membrane, increased lubricants, punctal occlusion. So many other things can be combined. You do all of these in hope to cross the first initial 1 year of period where it is very critical. So that is the critical period. Okay. So anything else you can think about? Is blinking important? All of us have same amount of blinking. Okay, so do you normally look at blink rate when you just sit for your slit lamp examination? It's very important. Okay, so you need to look at how the patient blinks. So as you set in your slit beam to focus on the cornea, first thing is you should look at how many times I think most of your patients will blink more because you will keep the rheostat at maximum. Yeah. So, but that should not be the thing. You keep it in low. You see the general broad view slit lamp. In that, you should see how the patient is blinking. The blink rate should be adequate. If the blink rate is less, just a warning to the patient that you should blink more after surgery. You should use more of teardrops. You should avoid exposure to air current while sleeping, while watching TV or something, while reading. That alone is enough to avoid the major complication of epi defect, corneal melt, failure, and so on and so forth. So that comes from pre-op evaluation. Okay. So apart from blink rate, is there anything else that you would look for? Log ophthalmos, blink rate. Patient is blinking normal. Patient does not have log ophthalmos. Is there anything else which can cause exposure? Bells. Okay. So bells is something which is very important. If the bells is not good, so then it can have corneal exposure. Sometimes the patient can have nocturnal log ophthalmos. That is also important to tell the patient. Ask somebody to watch. Okay. If you feel your epithelium is healing slowly, but limbus is good, otherwise everything is good, then that is one option which you should look at. Okay. Right.
Then comes the examination of donor. Detailed history has to be taken to avoid any contraindications, time of death, cause of death, blood reports, and serology. Contraindications of donor selection: death of unknown cause, congenital rubella, Reye syndrome, infective endocarditis, infective encephalitis, septicemia, suspected rabies, Down syndrome, active intraocular inflammation, active leukemias, prior refractive surgery, HIV, hepatitis B, HCV infection has to be ruled out. Then informed written consent has to be taken from the relatives. Donor corneal collection. By enucleation or in situ corneoscleral excision has to be done. Gross evaluation with pen torch. Look for any epithelial defect, DM folds, haziness, and signs of conjunctivitis, discharge. Slit lamp evaluation and then specular microscopy to know about the endothelial status, cell leomorphism, and corneal gut data. Storage media. Short-term storage was done with moist chamber in early days. It was used by V.P. Filatov in 1944. It is used to store whole eye. It can be stored only for 1 day. Then it was gradually improved. Today, cryopreservation was used to store corneas up to 1 year. And organ culture, with the help of organ culture, corneas can be stored up to 35 days at 31 to 37 degrees Celsius, which helps in tissue matching before transplant. Preoperative preparation. Infection control. Preoperative antibiotics and 5% povidone iodine is used preoperatively to reduce the risk of endophthalmitis. Look for any signs of blepharitis, which has to be treated preoperatively, as periocular flora is the most common cause of endophthalmitis. IOP control. In patients with glaucoma, IOP has to be controlled preoperatively, and complete extraocular akinesia and lid block has to be ensured before surgery, because extraocular movements during surgery will result in rise in intraocular pressure. And ocular compression, this reduces positive vitreous pressure during open phase of the surgery. Lens management. IOL status and lens status has to be evaluated preoperatively. If the patient is phakic and we are not planning the cataract surgery along with PK, the pupil has to be constricted. Donor cornea management. Before refining the donor cornea, look for any epithelial defect and foreign bodies, and anticipate suprachoroidal hemorrhage. Anesthesia. Local anesthesia or general anesthesia can be used. General anesthesia is used in patients with mental impairment, young age, aphasia, deafness, and language. Surgical technique. First, routine cleaning and draping is done. Globe exposure is made by insertion of lid speculum. Placement of scleral fixation ring. Can anyone please tell me why we use scleral fixation ring? Scleral fixation ring is used to fixate the globe, and it acts as a scaffold when the scleral rigidity decreases during the open sky phase. This is mostly used in pediatric PKs and aphakic eyes.
Oh, what is that Mac nail Goldman ring? It looks like the American.
Blepharostat or.
Okay, I have never seen that.
This is Fleringa ring, and this is used in our theatres, and this is McNeil Goldman ring, also known as blepharostat. It has two lid retractors to separate the lid, and it has temporal and nasal opening to allow more surgical space. Preparation of donor cornea. Donor cornea is refined on the endothelial side, which is 0.25 mm smaller than the epithelial side. So, we oversize the donor cornea during trephination. But in case of keratoconus, we use the same size. Why we use same size in keratoconus? Larger graft. Can anyone please tell me the indications of larger graft?
Okay. She is talking about oversized, yeah?
Larger graft, ma'am.
Larger
When we choose larger graft.
Okay. Limbus to limbus infection. Anything else? Anything else?
Ma'am, in cases of eccentric ectasias.
Okay. Which is ectasia that is limbus to limbus? You will do a lamellar limbus to limbus. What is that? Keratoglobus. Okay, when the involvement of the cornea is larger and the larger cornea is not sustainable, then you go for a larger graft. When the involvement is limbus to limbus, but the cornea is sustainable, you want to opt for only optical purpose, then you create only the necessary central window. Why? Why you stick to the central window even though the pathology, for example, macular corneal dystrophy, it's limbus to limbus. Limbus to limbus cornea is opaque, but you only create a central window of say 8 millimeter or 7.5 millimeter, leaving a peripheral rim. Why do we opt for that? One of you with the mic.
There are higher chances of graft rejection if it is limbus to limbus.
Yeah, so limbus to limbus means the graft comes closer to
Sclera.
the host blood vessels. Okay, so anything closer to the host blood vessel, higher risk of rejection. So you want to protect. Again, it boils down to the 1 year critical period. You want to retain the graft. You want to avoid rejection. So that is your best sizing. Okay.
Corneal Trifine system. Trifine is the term derived from the Greek word trypnon, meaning bore. It is used to produce a circular corneal incision to produce good post-refractive outcome. Initially, handheld trifines were used. It was introduced in 1930. Castoveggio handheld trifine was most popular during 1970s. Vacuum trifine. In vacuum trifine, Hesburg-Baron vacuum trifine is most commonly used. It has an outer ring with 16 compartment attached to a 6 ml syringe to produce more stability. Donor punch system. Baron donor corneal punch. Here, the corneal trifine is placed over the nylon block with the help of 4 stainless steel blades, and the nylon block consists of holes that can be inked for proper cardinal suture alignment. And recent advances being laser triffination by using femtosecond laser. Here, the donor tissue is placed on the artificial anterior chamber and femtolaser is being used for producing triffination. Cornea is marked using Castoveggio caliper, and Oceanman-Newman radial caliper is used for proper suture alignment if we are using interrupted sutures. Triffination of host cornea. Host cornea is triffined on the epithelial side and donor cornea is defined on the endothelial side. The most commonly used triffined size is 7 to 9 mm. This is the Teflon block over which the donor cornea is placed and triffined, and it has a central hole for drainage of viscoelastic. And this is patent spatula, and this has holes for the drainage of viscoelastic. This is used for placing the donor cornea over the host bed. Placement of viscoelastic in AC to reform the AC, then placement of donor corneal tissue in the host bed. Suturing of the donor cornea. Cardinal sutures are taken first at 12 o'clock, then at 6 o'clock. It is taken exactly 180 degrees away from the first suture and make sure that equally tissues are distributed on the either side. This is a most critical step as it plays an important role in avoiding the post-keratoplasty astigmatism. Other two sutures are taken at 3 and 9 o'clock. Then complete suturing is done. Various techniques are adopted. One is interrupted suture, continuous suture, combining interrupted and continuous sutures, and double continuous sutures. Can anyone please tell me the advantage of interrupted suture?
Better apposition. That is the foremost. Okay, because each suture is linked to the other. Whereas in interrupted, each suture is function on its own. The zone of tension overlaps and that only creates a complete closure. Whereas in continuous, that the tension is transferred to the other zone because of pulling of the suture itself. So that way the apposition of the graft host is more coordinated. But will that translate into less astigmatism? May not be. Okay, for astigmatism there are other things put into play, not just the position. Okay, but so that is the most important thing in the continuous suture. What is the disadvantage of continuous suture? Yes, the advantage is that it is a good apposition because it is continuous. The disadvantage is you cannot do isolated suture removal if it is a locally loosened. So you will have to remove everything and put everything. Okay.
Host cornea is being triffined and the cornea is dried with cellulose sponge, and the triffination has to be done till 90% depth, and AC entry is made with sharp blade. Then the entry is extended with castrovago-corneoscleral scissors and the host cornea is removed. Then a tucks of tissue is removed with Vanna scissor. Pupilloplasty is attempted and the donor cornea is placed over the host bed. Cardinal suture is taken at 12 o'clock and the second is taken at 6 o'clock. Other two sutures are taken at 3 and 9. And complete suturing is done with 16 interrupted suture. AC is reformed. This is combined interrupted and continuous suture.
So I was trying to do synecholysis in the side, no? This is a regraft, yeah?
Host cornea is measured, then the previous graft is removed by removing each suture. Host cornea is trephined using disposable trephine. Donor cornea is placed over the Teflon block and the center of the donor cornea is marked.
Assistant is also here. The assistant surgeon is also here.
Donor cornea is trephined and the donor rim is sent for rim culture. Then the donor cornea is placed in the preservative medium. Host cornea is trephined. AC is reformed with viscoelastic before proceeding with host removal with corneoscleral scissors. Donor cornea is placed over the host bed. Cardinal sutures are taken.
So this is a very large graft, 10 millimeter. So that is why you are having the corneoscleral rim. I'm putting the white portion is the scleral part. I'm putting it superiorly so that it will be hidden by the eyelids. This is a graft not just failed, it is also very ectatic. So this patient was taken under evisceration consent. That's why I made a larger graft than the initial failed size. Otherwise, you can just replace the same size graft. Here I've taken a larger one because the melt has increased, and so we have to remove the bit of host previous cornea also. I'm fixing an AMT on top so that we avoid a second melt. Anybody has any questions? You're done? Competition? Okay.
Post-operative care. Topical steroids 1% prednisolone or 0.1% dexamethasone is administered 10 to 12 times a day followed by weekly taper, and one time daily has to be continued lifelong. In topical antibiotics, ciprofloxacin, ufloxacin has to be given. Anti-glaucoma medications if the patient is previous glaucomatous patient, and cycloplegic and lubricants are also advised. Follow up, the patient has to be called on day 1, week 1, 1 month, 3 months, 6 months, and at the end of 1 year. Suture removal has to be planned at the end of 1 year. If the patient is having any astigmatism, the suture can be removed at around 3 to 4 months. If there are any suture related complication, the selective suture removal had to be done. Intraoperative complication. What will happen if we give poor anesthesia? Incomplete echinacea and lid block will lead to muscular movements intraoperatively. This will result in rise in IOP.
Definitely, you don't want that in an open sky procedure, right?
Scleral perforation. At what step scleral perforation can occur?
Please speak in the mic, no? How many times should I tell you? You can
Fleringa
perforate the sclera when you're manipulating it. So when do you manipulate sclera?
Fleringa ring application.
Okay.
Um,
So what do you do to avoid scleral perforation? Fleringa is anchored to what?
episclera.
Episclera. How do you make sure that you are piercing the episclera and not just the conjunctiva? How do you differentiate?
Resistance, like conjunctiva is much thinner and episclera will be thicker than visibility of the.
You don't know the thickness of episclera, but you feel something. You feel resistance. You rightly said. So when you pierce the suture needle and you have no resistance and it moves, the conjunctiva moves with your movement, then you are still in the conjunctiva. So you dig a little deeper. So when you feel hitched, you feel the resistance, you gently move, the globe moves, that means you have hitched the episcleras. Okay? So in that situation, you don't dig deeper. You try to go lamellar and then come out. To facilitate that, you have a curved needle. It's not a straight needle. So the angulation in the needle itself helps you in staying superficial. Right? So that way you avoid going through and through. When can you easily perforate? So this is the normal scenario when the scleral rigidity is
Thin.
as usual. Sometimes it can be lower. When that can happen?
Thin sclera, myopic patients.
In thin sclera, myopic patients, large eyes, large globes,
yes.
then very young patients. So you will have that issue. Then connective tissue disorder. So in these three situations, beware of your ring fixation. Okay. Is there any other place when you manipulate the sclera during these kind of surgeries? We do that very often in ECCs. Sometimes it might be required in PK also.
Large graft suture.
Bridal, superior rectus. So when you do superior rectus also, the same. There your suture is only muscle tendon. It's not scleral. But if you're not careful, there the suture has to go smoothly. It should not hitch. That's the reverse of your Fleringa ring fixation. It has to go smoothly. You have to take the bulk of the muscle in your hold and you go underneath that so that it is purely conjunctival but below the bulk of the muscle and definitely not on the sclera. Okay, so that way you go, and that is a, what type of needle is that? Atraumatic round taper tip. Okay, whereas here bridal suture is that, right? That needle is taper tip. Here it can be spatulated. Why can't you use a spatulated needle for conjunctival perforations? It can tear up. So you want to make a rexis like a round thing in the conjunctiva. If you take a spatulated needle and make a hole in the conjunctiva, it can tend to rip even after the surgery is over. Okay, so that's the difference.
Improper trephination. Can anyone please tell me what's the figure depicts? It is the double anterior chamber seen in retained host descemet membrane. Inadvertent entry into AC with the help of corneoscleral scissor. If the corneoscleral scissor entry is done before the descemet membrane, the host descemet membrane is retained inside and double AC formation is seen post-operatively. This subsequently leads to corneal cloudiness and graft failure.
It might seem like an impossible event, but we do see in the practice patients with failed grafts come to us, and then when you do an ASOCT, the host decimates is still full length retained. Sometimes it can be close to the graft with normal chamber. Sometimes it can be shifted down, forming double anterior chamber, and sometimes it can totally lie on the iris, detached and lying down on the iris. So it's important in these situations to do an ASOCT. Okay, after the introduction of ASOCT, these kind of problems are recognized everywhere. Okay, these are more common in the times when we didn't have an ASOCT to diagnose these things. Okay, so no, failed graft sometimes can be just a host decimate retained.
Endothelial damage in case of improper tissue handling, intraocular hemorrhage, then vitreous loss.
So the routine way of protecting the donor endothelium is putting a blob of viscoelastic on the endothelium while handling it, placing it on the host bed, and you also put a little bit of OVD in the chamber so that it gives that sufficient cushioning effect. And you have to be careful when you form the chamber or whenever you enter and exit through the graft host junctions in order to avoid the instrument or the flow pointing towards the endothelium. So those are very critical because the amount of endothelium retained in the graft is what the patient is going to get for the rest of their lives. So that's how important it is to bear in mind.
Suprachoroidal hemorrhage. Incidence is around 0.45 to 3.3%. Can anyone please tell me what are the risk factors of suprachoroidal hemorrhage?
I think we have discussed it already, so we'll skip.
Glaucoma, myopia, trauma, and inflamed cornea. Preoperative hypotony achieved by ocular compression, complete ocular achalasia and lid block, and control of IOP and systemic hypertension. Slow globe decompression during AC entry is strongly recommended. Suprachoroidal hemorrhage, if occurs, it's seen as dark shadows or dark brown masses against the red reflex. The expulsive intraocular hemorrhage results in extrusion of intraocular contents outside, and this can be prevented by closing the wound with finger or hand, which followed by posterior sclerotomy made by stab incision in the inferotemporal quadrant. In unsalvageable situation, evisceration is the only option. Early postoperative complications. Wound leak can be detected postoperatively by positive Seidels test. If the patient is having shallow AC with a low IOP and wound leak without iris incarceration, we can wait up to 3 days before proceeding for resuturing. If the patient has iris incarceration, then the iris has to be reposited back and AC is reformed and the wound has to be resutured immediately. Suture-related complications like loose suture, tight suture, suture exposure, eroded suture has to be addressed by selective suture removal. Can anyone please tell me what is this?
How many times should I take the mic?
Pooling of stain at the site of loose suture, or in that case, it's a snapped suture.
Is it just pooling of dye? Show me the picture that you are asking.
Bottom left.
Bottom left, ma'am.
Which one? That's just a pooling of dye?
This picture.
Is it pooling of dye? What do you think?
This is infected suture abscess.
You can't see an infiltrate there. When suture rubs, it causes an epithelial defect. See, this is an infiltrate.
Okay, ma'am.
Yeah? So this cannot be missed exactly at the graft host junction. Yeah?
Yes, ma'am.
That is what you should look at. So this bump is also telling us that there is a surface irregularity. Yeah?
Okay.
So the stroma is swollen and correspondingly the graft is edematous.
Yes, ma'am.
So here the suture is little loose. Yeah? It has snapped also here. It should have been like that. Yeah?
Yes,
So
ma'am.
and that area is having an infiltrate. So loose sutures can rub initially, cause an epithelial defect. Slowly it can erode and then infection. It is an opportunistic infection most likely. Okay. So it is important to remove the suture on time. Yeah.
What is this picture depicts?
Quickly, no, this is all. What is here? What are they? Is this an infiltrate? Deposits. Because the eye is quiet and this is not a deposit. This is an infiltrate. Correct? So that's what we want to do. And this one is epidefect. Epidefect stain. What illumination is used? Chorus. Blue filter illumination. What this thing? Huh?
Fluorescein dye.
Fluorescent dye, blue filter illumination. Anything else? Diffuse slit?
Oh yes, diffuse.
Yeah.
Low.
So that, yeah. Okay.
Post-keratoplasty astigmatism. Average post-keratoplastic astigmatism can occur around 4 to 5 diopters. High preoperative astigmatism in conditions like corneal ectasias, peripheral marginal, pellucid marginal degeneration, then keratoconus. Intraoperative factors. What are the intraoperative factors can lead to post-keratoplasty astigmatism? From trephination technique, can anyone please tell?
Ma'am, small graft, because it is closer to the visual axis.
Small graft because it is closer to the visual axis. Anything else can cause?
Tight suturing or loose suture. Tight suture.
If tight equally all, then no problem. So irregular or variable tightness on length, okay, of the sutures. Anything else? Equidistant. Okay. Radially placed. If they are not radially placed, again they can cause astigmatism. Anything else? Depth of suturing. It has to be even. Even. Okay. So having said that, the graft will always be more or less equal in thickness. Because of the conditions of preservation and everything, it will be thicker than normal, but it will be equally thicker. The host bed may not be, depending upon the disease status. It can have variable thickness. So you have to bear that in mind when you do the suturing. Okay? That's it. We'll go ahead.
It is managed by selective suture removal. And in cases of higher degrees of astigmatism, regrafting is also advised.
I'm just going to tell you, this is not a very good picture. This one is supposed to be a tight one. Yeah? So after removal, this thing is, the irregularity is gone. This is also not working. Okay, basically, okay. Tight suture causing those Myers distortion. After removal, okay, this is not a great picture. We'll move on.
High-risk graft. The eye is said to be in immune privileged status. Why? Because of lack of vascularity, lymphatics, immunomodulators in the aqueous humor, presence of CD95 fast ligand. High-risk corneal grafts. High-risk corneal grafts includes stromal vascularization involving more than 2 quadrants, prior history of graft loss, larger grafts, anterior cynic A, intraocular surgery or inflammation, HSV keratitis, and age less than 40.
Sort of, we have talked about it.
Graft rejection. What is the difference between primary graft failure and graft rejection? Primary graft failure. It occurs in the graft appears edematous from the post-operative day 1. It occurs before 14 days of the surgery. This is due to deficiency of the endothelial cells in the donor. The surgeon can wait up to 2 weeks to 2 months, then can go for regrafting. Graft rejection. Graft rejection is an immune-mediated mechanism. The previously clear graft suddenly turns edematous and it goes in for decompensation. It occurs mostly after 14 days of surgery. The types include epithelial, subepithelial, stromal, and endothelial. What are the symptoms of graft rejection?
Conjunctival injection,
Okay.
pain,
Okay.
decrease in vision.
Okay.
Yes, symptoms will be these. Signs can be we can have conjunctival injection, the AC reaction in cases of endothelial. We can have epithelial rejection lines, endothelial rejection lines, KPs in cases of stromal or endothelial rejections.
Graft haziness.
Graft haziness. Yes.
Localized or diffuse haziness based on the type.
Yes, ma'am.
Okay. And what else?
Ma'am, vascularization of like more than 2 quadrants or yes,
Okay.
formation of
Okay.
bullae.
Okay.
Epithelial rejection. Epithelial rejection is characterized by presence of epithelial rejection line which extends to the periphery, and it is seen near the vascularization, and the patient is initially asymptomatic, but sometimes they may present with blurred vision if it involves the central cornea. It usually resolves spontaneously. This is the picture showing subepithelial infiltrate. In case of chronic stromal rejection, subepithelial infiltrate is an wide ovoid bodies seen beneath the Bowman's layer.
Okay. So both epithelial rejection and endothelial rejection can have lines. Yeah. We agree to that? Okay. So when you look at the depth in a slit view, you know at what level it is involved, so you can easily differentiate. But when you are given a picture where you are not able to assess the line, there is a line, it could be an epithelial or an endothelial rejection line. What is the one question you will ask relative to understand whether it is epithelial or endothelial? One question that you want to ask about.
Ma'am, symptomatic.
Okay.
Endothelial patients will have lot of pain and decrease in vision will be more. Epithelial is not that symptomatic. They can be symptomatic.
Relative.
Ma'am,
Relative.
acute presentation or
Okay. More classical, more important. When will this happen and when will that happen?
ma'am, epithelial will be more acute, like
Earlier
these
days.
early
Why?
because the epithelial host epithelium is grown after
So that is
Yes.
an irrevocable
yes.
condition. Okay. So the epithelium is, the donor epithelium gets replaced by the host epithelium. How long it takes? Beyond this period, it is replaced in 100%. What is that cutoff? 3 months, 2 to 3 months. So anything that happens, so you will ask when the keratoplasty was done. That one question itself will give you the answer whether it is epithelial or endothelial. If it is 6 months, you know it is endothelial. If it is 1 month, it could be either or. Then you ask about the symptoms and all those things. Okay?
This is a picture of hyperacute stomal rejection. In hyperacute stomal rejection, the stomal head starts in the periphery and it involves the central corneal stroma within 24 hours of onset, and it responds poorly to medical treatment. And last 3 pictures, endothelial KPs, endothelial rejection line. What is the name of this line? Yeah. These are pathognomic of endothelial rejection. In endothelial rejection, the patient presents with acute onset of pain, photophobia, and drop in vision, and it is an emergent condition which has to be addressed immediately. Management. Non-endothelial rejection is treated with topical steroids, 1% prednisolone or 0.1% dexamethasone, 10 to 12 times a day, and tapered weekly. Endothelial rejection is treated with IV methylprednisolone 500 milligram or oral prednisolone 1 milligram per kg per day for 5 days. Immunosuppressants and prophylactic antivirals are given in prior history of HCV infection. According to Hill study 1991, the oral corticosteroid therapy was compared with single pulse IVMP. Pulse IV methylprednisolone 500 mg single dose was tolerated better than the oral corticosteroids when it is combined with topical steroids. Oral immunosuppressants are prescribed in high-risk grafts and prophylactic antivirals were advised in prior HSV infection. Prevention. Graft rejection can be prevented by minimizing antigenic differences between the host and donor. Reduction of antigenic load of donor tissue by proper graft centration, removal of donor epithelium, exposure of donor tissue to UV light, hyperbaric oxygen, depletion of local macrophage from donor tissue by subconjunctival injection of clodromate liposomes. All this removes the antigen presenting cells, Langerhans cells from the donor tissue. Suppressing the host immune response by preoperative reduction on host bed vascularization, by treating the host bed by irradiation, argon laser, and immunosuppressants can also be given preoperatively. Collaborative corneal transplant study 1992. This study evaluated the efficacy of donor-host histocompatibility matching and cross-matching in predicting the survival of corneal transplant in case of high-risk grafts. Two controlled double-mask studies, cross-match study and antigen matching study was done. The results being in ABO cross-matching study, the graft failure at 3 years was 41% in ABO incompatible group and 31% in ABO compatible group. And graft rejection at the end of 3 years is 30% in ABO incompatible group and 16% in ABO compatible group. So the results are found to be HLA typing has no significant long-term effect, but ABO compatibility is found to be more useful.
Do we do any matching in grafts? We don't. Yeah, but about the study you should know.
Femtosecond laser assisted penetrating keratoplasty. The first femtosecond laser platform was Intralase and second was Femtech. Donor cornea is cut by pre-programmed parameters set by the surgeons. Advantages being more stability, faster visual recovery, and higher optical quality. Contraindications include peripheral neovascularization, previous glaucoma surgeries, and narrow palpebral fissure. This is the picture showing 1 month post-operative cornea following femtosecond laser assisted PK, and the magnified view shows good tissue apposition.
You need to learn about the types of cuts and all those things. If this comes as a separate question, you need to run through all the types of cutting and how the suturing is done, advantages, disadvantages, more elaborate, which is just a touch-up.
Autorotational keratoplasty. This is done in cases of non-progressive central corneal opacity. Here, the central opaque cornea is rotated to the periphery so that the peripheral clear cornea comes into the optical axis.
Here we have the opacity. The rest of the areas the cornea is clear. You cut a portion of it and rotate it in such a way that the central area gets cleared. Okay?
Advantages: no rejection, vascularization, easy postoperative care, and lesser endothelial cell loss. But the disadvantages: limited patient selection, higher postoperative astigmatism, chances of anterior synechiae, glaucoma, and cosmetic blemish.
Most importantly, surgically very challenging. You have to cut from the same cornea. You cannot have any ledge. That becomes a gap. So you'll have to be very precise in your cutting.
According to Brubaker et al., the required refined diameter in autorotational keratoplasty can be calculated by this formula: 1.5 into largest diameter of clear circle plus shortest distance from circle to the corneal center. This is the largest diameter of the clear circle, and the distance between the margin of the circle and the center is 0.75. as the center of the cornea lies within this circle, so this 0.75 has to be subtracted. So 1.5 into 6.5 minus 0.75. So 9 mm corneal trephine is chosen. And here the center is located out of the clear margin. So it has to be added. So 1.5 into 5 mm plus 0.5 is equal to 8 mm trephine size is being chosen.
Little bit of math.
These are my references. Thank you.
Excellent. Very good.